Thank you for your instruction. Good afternoon. My name is Hyun from Ulsan Medical Center, Korea. I'm going to talk about issue regarding current status of heart transplantation in Korea. Currently, heart transplantation is annually increasing with time, reaching 190 cases annually. But actual rate of donor utility is still substantial in relation to actual number of deceased donor. Mean donor age was about 41 years old in Korea and slightly lower in first year and slightly increased with time. So in overall, from international data suggests an increasing trend of donor age and also true in Korea. As previously known, donor age was significantly affect post-transplantation survivor in all age category. In Korea, donor age does not significantly affect post-transplantation survivor from Korean data. Donor age does not significantly matters, but recipient age does matters after transplantation outcome in Korea. Gender mismatch was about 30% of total heart transplantation in Korea and does not significantly affect post-transplantation survivor in Korea. It is quite different from UNOS data result. UNOS data reported that gender mismatch affect post-transplantation survivor in those, especially in those with undersized donor. But in Korea, female recipient receiving either female or male donor shows comparable outcome after transplantation during 5 years and 1 year. Although there are some trend to show a lower survivor in those with female recipient receiving male donor. Male recipient receiving either male or female donor shows comparable outcome during 5 years and also for 1 year. It is quite different from UNOS data report. Male recipient receiving female donor received somewhat small heart for about 90%, but female recipient receiving male donor heart was quite large for about 46%. It is quite different from UNOS data report. Undersized donor has similar degree, but oversized donor was much oversized than United States. Recent report from Korea suggests significant proportion was size mismatching, but male recipient receiving female donor heart was somewhat slightly undersized, but female recipient receiving male donor heart was largely oversized. When we look into the data, size mismatching was not significantly affect post-transplantation survivor, but it is true that size mismatching affect post-transplantation survivor. For about 1 year after transplantation, as you can see, donor undersizing was matter in Korean data. It is quite contrary result to international data. When dividing quartile, donor oversizing was matter than donor undersizing, as you can see in these graphs. When comparing two graphs, donor oversizing was exposed to higher risk for post-transplantation mortality than well-matched control. When looked into data deeply, donor oversizing and donor undersizing has comparable characteristics regarding cold ischemic time, recipient age, and pre-transplant support. But there are clear trend that donor oversizing was high donor age and higher proportion of ischemic etiology of heart failure. So we have to interpret this data cautiously. Some bias can intervene. Korean allocation system gives a priority with blood type. Blood type O donor was transferred to other blood type in about 1/3 of patients. It is much higher than other blood type. Therefore, waiting time of blood type O recipient was significantly longer than other blood types, median 133 days. Therefore, blood type O candidate waiting for heart transplantation was transplanted in status 0 and higher proportion of ECMO support or APCIS support. Donor utility rate was reported to be 31%. It is similar rate with international data or United States data. Overall survival of heart transplantation in Korea was about 80% for about 5 years. Recipient age was mean 53 years old and the age was increasing with time gradually. Recipient age was significantly affect post-transplantation outcome, similar with international report. But in Korea, there are some special divergency early after heart transplantation. Recipient aged over 70 years old has a higher risk of 4.5 risk of mortality compared with aged under 50 years old. When dividing a recipient age category with different category, there are significant difference, and especially interestingly, ECMO support impact of ECMO support has shows differential with age category. Younger age without ECMO support shows some small divergence in outcomes, but elderly patient without ECMO support shows large divergence of a survivor after transplantation. So, elderly patient with pre-transplant ECMO support exposed to highest risk of adverse event after transplantation. In Korea, recipient who transplanted in status 0 was in about 1/3 of patient and poor outcome. Recipient who received pre-transplant ECMO support was about 31% and shows poor outcome. Rates of ECMO support before heart transplantation was higher than international data and other countries. It is still a problem in Korea. It is well known that recipient who transplanted bridged with ECMO support shows poor outcome after transplantation. It is similar with international data and in Korean data. Median waiting time was 80 days and gradually increasing with time. It is also true in patients with pre-transplant ECMO support. In 2020, patients who are waiting for transplantation with ECMO support, the patient have to wait over 3 weeks for transplantation. Ischemic time was not different with times and does not significantly affect post-transplantation survivor. It is quite different research with international data. Maybe it is because of Korean geography, which is we can reach to other region maximally for about 4 or 5 hours. In summary, heart transplantation is gradually increasing in Korea, but there are still problems regarding increasing trend of waiting time, aging population in both donor and recipient. Pre-transplant ECMO support bridged to heart transplantation was much higher rate than international report. We have to discuss about interpretation of contrary research of size mismatch and ischemic time. I will talk about some small challenging cases from our center. A female 63 years old presented with dyspnea, and she had ischemic cardiomyopathy showing a profuse shock requiring ECMO support. She was stable with ECMO support, but her main problem was high sensitization level. So we have to decide to keep waiting her transplantation or ECMO winning. With minimal ECMO support, she was stable, so we decided to try to remove ECMO support, but sooner after there, she shows a hemodynamic collapse and we have to re-implant ECMO. After there, she shows extension bowel resection requiring surgery. Her remnant bowel length was 2 meters. After there, she was stable with ECMO support. She did not have any neurologic deficit, but her main problem was high sensitization level, and she also received extensive bowel resection and has had a potential risk for short bowel syndrome. Luckily, she can undergo her transplantation at hospital day 46 with B-flow cytometry was weak positive. Immediate after her transplantation, she shows severe allograft dysfunction requiring ECMO support. Immediately, we treated with immunotherapy, and she recovered. She was hospitalized about 4 months after transplantation, managing short bowel syndrome and cytopenia. Until now, she survived 2 years and 3 months after her transplantation, and she can be able to perform self-ambulation and ADL without any assist. Thank you for your listening.